Assessment on you today. What is your name?
I'm Macho Man Randy Oliver.
Oh, you are related to Beverly Oliver.
Yeah, she's my sister.
Yeah, just saw her last week. How's she doing?
Oh, she's doing good.
Awesome. Okay, so what brings you in today?
I've just been having some musculoskeletal pain in my back.
Yeah. Okay, well today we'll be doing a musculoskeletal exam for you.
Sounds good, brother.
Okay, first part of this assessment will be the assessment of the jaw.
We're going to assess the temporomandibular joint by placing the tips of your fingers in front of the tragus of the ear. Then ask the patient to open and close his mouth, feeling for smoothness of the joint.
Open and close.
Note any swelling or tenderness or crepitus. Next, palpate the muscles of mastication, including the temporal muscles, the pterygoid muscles, and the masseters. After doing so, ask the patient to demonstrate protrusion and retraction by jutting the mandible forward.
Can you protrude your bottom jaw, please? Okay.
And then ask the patient to demonstrate lateral side-to-side motion of the jaw.
And move your jaw side to side. Perfect. Now we're going to do a shoulder assessment.
Sounds good.
We're going to begin by inspecting the shoulder and the shoulder girdle anteriorly. Next, inspect the scapula and related muscles posteriorly. During both inspections, note any swelling, deformity, muscle atrophy, or fine tremors of the muscles. Next, palpate the sternoclavicular joint and trace the clavicle laterally with your fingers. From behind, feel for the bony spine of the scapula and trace laterally upwards until it becomes the acromion. Palpate the acroclavicular joint from there down to the coracoid process of the scapula. Next, palpate the greater tuberculum and the biceps tendon in the intertubercular groove, checking for tenderness. Next, lift the humerus posteriorly so you can palpate over the subacromial bursa.
Okay, now we're going to assess the range of motion in your shoulders.
All right.
First, we're going to test flexion, having the patient raise his arm in front and overhead.
Cool.
Extension, where he moves his arm behind. Abduction, raising his arms out to the side and overhead.
Oh, sorry.
Adduction, having the patient cross his arms in front of his body. Internal rotation, placing a hand behind his back to touch his shoulder blade.
Sorry, my muscles are too big sometimes to scratch my own back. Ugh.
And external rotation, rotating an arm towards the ceiling from shoulder level. If you suspect any problems, cup your hand over the patient's shoulder and feel for crepitus as the patient repeats the movement. Next, we'll perform the crossover test. Then the Apley scratch test to assess overall shoulder rotation. Next, using the Neers and Hawkins impingement sign, we'll assess the rotator cuff.
Let me know if you're having any pain doing this.
Ugh. Sorry, I tore my rotator cuff in a cage match with The Undertaker years back. Ugh.
Next, we're going to test the sits muscles, using the empty can test to assess the supraspinatus.
Let me know if you have any pain doing this.
Nope.
Next, to test the infraspinatus, you're going to keep your thumbs up and press out against the hands.
Go ahead and press out against my hands and let me know if you have any pain.
Nope.
Now to test for supination, have the patient attempt to turn hands like holding a bowl of soup.
Go ahead and try and turn. Any pain?
Nope.
The drop arm test will be performed next by asking the patient to fully abduct the arms to shoulder level and then slowly lower them.
And go ahead and lower. Any pain?
No.
If positive, these tests can suggest a rotator cuff sprain, partial tear, or full tear.
I'm going to assess your elbow.
First, support the patient's forearm so the elbow is flexed up to about 70 degrees. Inspect and palpate the elbow, including the medial and lateral epicondyles, the olecranon process in the groove between the epicondyles, and the extensor surface of the ulna. Note any nodules, swelling, pain. Next, we're going to assess the range of motion of the patient's elbow. First, we're going to test flexion and extension by having the patient bend and straighten at the elbows.
Any pain while doing that?
No.
Next, to check supination and pronation, have the patient flex his elbows at 90 degrees and turn his palms up and then down.
You like to show off your muscles, don't you?
Sorry.
Go ahead and turn your palms up and down for me. Any pain?
No.
Good. We're going to do the hand assessment.
First, inspect the patient's wrists and hands, noting any swelling over joints as well as any deformities. Pay attention to the palm and notice any thickening of tendons or fingers. Palpate the distal radius and ulna on the lateral and medial surfaces of the wrist. Next, palpate the radial styloid bone and the anatomical snuff box. Pain when palpating the snuff box suggests a scaphoid fracture. Next, palpate over the 8 carpal bones lying distal to the wrist joint. Then each metacarpal phalangeal joint. Compress each MCP joint by squeezing the hand from each side between thumbs and fingers. Note any tenderness, swelling, or bogginess. Next, you're going to palpate the proximal and distal interphalangeal joints using your thumb and index finger. Note any swelling, bogginess, bone enlargement, or tenderness.
That's the range of motion in your hands.
First, begin with flexion and extension. Then assess wrist movement with adduction and abduction.
Move your hands out to the side and back in. Good.
Next, check for ulnar or radial nerve damage, assessing the 5th finger and thumb.
Okay, let me know if you have any pain here.
No.
Any pain here?
No.
Next, check for carpal tunnel syndrome, first using thumb abduction.
Okay. Any pain?
No.
Then perform Tinel's sign.
Any pain here?
Nope.
And Phelan's sign.
Go ahead and do this for me. Any pain in your 2nd, 3rd, or 4th fingers?
Nope.
Both of those assess for medial nerve compression.
Now we're going to do an assessment of your spine.
First, assess the patient's posture, including the position of the neck and trunk. Have the patient stand in a neutral position, feet together and arms at side. Next, from behind the patient, identify the spinous processes and palpate from the cervical down. Inspect and palpate the facet joints that lie between the cervical vertebrae at the neck. Inspect and palpate the paravertebral muscles for tenderness and spasm. You can also palpate the sacroiliac joint, often identified by a dimple in the patient's back. If you were to need to assess for sciatica nerve pain, you would have the patient lie on one side with the bottom leg extended and the upper leg flexed at the hip and palpate the nerve that lies midway between the greater trochanter and the ischial tuberosity. While palpating all of these, note any symmetry, deformities, swelling, or abnormal posture.
You assess range of motion of your spine.
First, begin with assessing the range of motion of the cervical spine. Test flexion by having the patient touch his chin to his chest. An extension by having the patient tilt his head back. To check rotation, have him turn his chin to his right shoulder and then his left. To assess for lateral bending, ask the patient to bend his head towards his right shoulder and then left. Next, for range of motion of the lower spine, begin with flexion. Have the patient bend over and touch their toes. Once the patient is standing up again, assess the height of the shoulders. Unequal height could suggest scoliosis. Next, move on to extension, having the patient lean back.
Lean back for me? Good.
The next maneuver is rotation, having the patient rotate right to left.
Any pain doing that?
Nope.
Next, assess lateral bending, having the patient bend to his right and then his left. Any pain or tenderness with these maneuvers warrants additional neurologic testing. Now we're going to examine your hips.
Inspection of the hip begins with careful observation of the two phases of the patient's gait. Stance when the foot is on the ground and bears weight, and swing when the foot moves forward and does not bear weight. Normal gait has a smooth, continuous rhythm. Most hip problems appear during the weight-bearing stance phase. Palpate the bony landmarks, including the iliac crest at the upper margin of the pelvis at the level of L4. From there, you can follow the downward anterior curve to locate the iliac tubercle, marking the widest point of the crest. Tracking downward, you'll find the anterior superior iliac spine. Place your thumbs there and move your fingers downward to find the greater trochanter of the femur. Move your thumbs medially and obliquely to the pubic tubercle. On the posterior aspect of the hip, palpate the posterior superior iliac spine directly underneath the visible dimples just above the buttocks. Next, locate the greater trochanter at the level of the gluteal fold and place your thumb medially on the ischial tuberosity. The sacroiliac joint is not always palpable but may be tender. Note that an imaginary line between the posterior superior iliac spine crossed the sacroiliac joint at S2. Palpate along the inguinal ligament. Here, the femoral nerve, artery, and vein bisect the overlying inguinal ligament while the lymph nodes lie medially.
We're now going to assess range of motion of the hips.
First, check flexion. With the patient supine, place your hand under the patient's lumbar spine. Ask the patient to bend a knee up to the chest and firmly against the abdomen. Note when the back touches your hand, indicating normal flattening of the lumbar lordosis. Further flexion must arise from the hip joint itself. Observe the degree of flexion at the hip and knee. Normally, the anterior portion of the thigh can almost touch the chest wall. Note whether the opposite thigh remains fully extended, resting on the table. If the opposite thigh flexes, there may be a flexion deformity of the hip. Next, check extension. Have the patient hyperextend the thigh in a posterior direction. Check abduction next. Stabilize the pelvis by pressing down on the opposite anterior superior iliac spine with one hand. With the other hand, grasp the ankle and abduct and extend the leg until you feel the iliac spine move. This movement marks the limit of hip abduction. Next, check adduction. With one hand on the patient's opposite hip, hold one ankle and move the leg medially across the body and over the opposite extremity. Test internal and external rotation of the hip. When this helpful test is normal, hip arthritis is less likely. Flex the leg to 90 degrees at the knee. Stabilize the thigh with one hand and grasp the ankle with the other. Now swing the lower leg medially for external rotation at the hip and laterally for internal rotation. Repeat each of these maneuvers on the opposite side.
Next, we're going to assess the knees.
With the patient supine on the examining table and with his knees in flexion, inspect the knees, noting their alignment and any deformities. Note loss of the normal hollows around the patella or atrophy of the quadriceps muscles. Then straighten the patient's leg and palpate the suprapatellar pouch on each side of the quadriceps, noting any swelling. Palpate the tibiofemoral joint, the edge of the tibial plateau, and the margins of the joint. Note any irregular bony ridges. Palpate the medial meniscus. Then palpate the lateral meniscus. Tenderness may suggest a partial tear. With the knee flexed 90 degrees, assess the medial joint compartments for any tenderness. Palpate the medial femoral condyle, the adductor tubercle, and the medial tibial plateau. Also palpate any and identify the medial collateral ligament. Assess the lateral joint compartment and palpate the lateral femoral condyle, the lateral tibial plateau, and the lateral collateral ligament.
We're going to assess the range of motion of your knee.
Assess the range of motion of each knee beginning with flexion and extension. Be sure to provide support as needed. Check internal and external rotation of the knee.
Have your feet laying down and turn your feet in and out.
Instruct the sitting patient to swing the lower leg toward the midline and away from the midline. You have already palpated the menisci for tenderness, 2 of the 7 major structures of the knee of the joint. To test the medial collateral ligament, or MCL, perform the adduction or valgus stress test, where you move the thigh about 30 degrees laterally to the side of the examination table. Push medially against the knee, and pull laterally at the ankle to open the knee joint on the medial side. Injuries from trauma or sports to both the medial meniscus and the MCL are common. The lateral collateral ligament, perform the adduction or versus test, where you push laterally against the knee and pull medially at the ankle to open the knee joint on the lateral side. To test the anterior cruciate ligament, or ACL, check for the anterior drawer sign, where you draw the tibia forward and observe if it slides forward like a drawer from under the femur. To test the posterior cruciate ligament, or PCL, check for the posterior drawer sign, where you push the tibia posteriorly and observe the degree of backward movement in the femur. Now ask the patient to extend the leg to check the integrity of the patellar tendon.
Next, we're going to examine your ankle.
With the patient supine, inspect the patient's ankles and feet. Note any deformities, nodules, swelling, corns, or calluses. With your thumbs, palpate the anterior aspect of each ankle joint, noting any bogginess, swelling, or tenderness. Feel along the Achilles tendon for nodules and tenderness. Palpate the heel, especially the posterior and inferior calcaneus for tenderness. Palpate the plantar fascia as well. Palpate over the medial and lateral malleolus, especially in cases of trauma. The forefoot and the metatarsophalangeal joints for tenderness. Palpate the heads of the 5 metatarsals and the grooves between them. To assess the range of motion of the ankle, begin with the ankle flexion and then ankle extension or dorsiflexion. Evaluate the inversion of the ankle and eversion of the ankle. Stabilize the heel and invert and evert the forefoot. Lastly, move the proximal phalanx of each toe up and down. There should be no limitation of movement or pain.